Hello friends, today's topic is mucormycosis. Mucormycosis is the fungal infection generally caused by filamentous molds and it belongs to mucorale and entophthalmorale order. So mucormycosis is most common in highly immunocompromised hosts in developing countries. In developed countries, the mucormycosis is commonly seen in patients with bad prognosis regulated diabetes mellitus. Furthermore, patients suffered from trauma is also prone to mucormycosis. Mucormycosis has strong proclivity to invading blood vessels, causing necrosis, thrombosis, and tissue infarction. So, absorption and the inhalation of the sporangiospores and inoculation of the conidia by puncture, trauma, and wounds are initial step in the pathogenesis of mucormycosis. Mucormycosis nosocomial outbreak have been attributed to surgical instrument, infected bandages, breathing system, but they are exceedingly rare. Polymorphonuclear phagocytes and the mononuclear destroy the hyphae and fungal spores in healthy young people using oxidative killing mechanism and non-oxidative killing mechanism. Deficiencies in the phagocytic behavior encourage the organism's survival and development. Acidosis and hyperglycemia, in particular, hinder the phagocytic killing and chemotaxis. The enzyme ketone reductase is also generated by rhizopus, which allows it to expand in acidic and glucose-rich condition like ketoacidosis. So it was clinically observed that patients with the iron overload are more prone to mucormycosis. On the other hand, deferoxamine stimulates in vitro fungal development by acting as mucorale siderophore. So, mucormycosis has the penchant to attack the blood vessel, causing thrombosis, tissue necrosis as a result. Angio, Angioinvasion may be aided by endothelial cell associated with the fungal spores. So, diabetes mellitus is the most common predisposing factor as diabetes is previously undetected in one case. And the mucormycosis is presented as rhinocerebral pulmonary manifestation, GI manifestation, and disseminated manifestations. Now we will see what are the risk factors for the mucormycosis. So the risk factors for mucormycosis are the diabetes mellitus, hematological malignancy with the neutropenia, organ transplantation, prior recipient of the voriconazole, malnutrition, peritoneal dialysis, trauma including surgery, then burns, iron overload, human immunodeficiency virus, immunosuppressive therapy, autoimmune disorder, and diabetes mellitus. So, an increased incidence of the invasive fungal disease is linked to the corticosteroid medication and history of chronic lung disease. So, regarding poorly controlled diabetes mellitus, mucormycosis is well-known impediment of largely unregulated diabetes mellitus. It is linked to the innate immunity defects like phagocytosis, chemotaxis, and killing by the polymorphonuclear cells, as well as macrophages and monocytes. Diabetes mellitus is the proximate cause of mucormycosis in 27% to 52%. Rhinocerebral type of the mucormycosis is most common in diabetes with the ketoacidosis. Sinuses are the most prominent initial source of involvement, and they may even extend to the orbit, brain, and bone. In diabetes-associated pulmonary and mucormycosis or disseminated infection are rare, unlike in the transplant patient and recipients with the hematological malignancies. Now, organ transplant recipient. Mucormycosis is relatively uncommon impediment in single organ transplant recipient. So numerous case reports are limited. Sequence of the mucormycosis in single organ transplant recipient have been reported, including kidney, liver, kidney, heart, and lung recipient. Now regarding immunocompetent host, in India, 3% to 26% of mucormycosis cases have been recorded from the immunocompetent host, compared to the 18 to 19% globally. Cutaneous and isolated renal mucormycosis were common in Indian patients. However, trauma is the risk factor in 7.5 to 22% of mucormycosis cases in India. The majority of the patients present with the cutaneous mucormycosis after trauma, burns, and nosocomial infection at surgery or injections. Contaminated intramuscular injections, surgery, adhesive tapes, endobronchial tubes are the source of infection in nosocomial mucormycosis. Isolated renal mucormycosis in immunocompetent host is an emerging entity in India. So factors associated with the mucormycosis in India are chronic kidney disease, steroid therapy, pulmonary tuberculosis, and chronic obstructive pulmonary disease. CKD is the new risk factor for mucormycosis in India. Pulmonary tuberculosis and COPD are seen in 7% to 46% of patients with mucormycosis. A few cases of breakthrough mucormycosis after voriconazole treatment were reported in India. Other risk factors reported in India include intravenous drug use, autoimmune disease, HIV infection, and immunosuppressant drug, malnutrition, and ICU stay. Now regarding diagnosis. A high index of suspicion and identification of the host conditions, a rapid evaluation of clinical symptoms are all needed for diagnosis of mucormycosis. So the diplopia in a diabetic patient and the pleuritic pain in a neutropenic patient may be signs of infection, prompting the use of imaging techniques and eventual collection of specimen for histology, microbiology, and advanced molecular research. As stated earlier, rhinocerebral, pulmonary, soft tissue, and disseminated infection are the most frequent clinical manifestation of the mucorrheic infectious disease. So the mucormycosis is characterized by tissue necrosis. However, the appearance and syndrome-based methods of diagnosis lack sensitivity and accuracy. A history of the history of previous voriconazole prophylaxis or occurrence of breakthrough fungal infection in immunocompromised patient receiving antifungal agent functional against aspergillus. Cranial nerve palsy, sinus pain, diplopia, periorbital swelling, proptosis, and palate ulcers, orbital apex syndrome are among the signs and symptoms that can be called red flag. Mucormycosis is said to be associated with numerous nodules and pleural effusion on radiology. The reverse halo symbol is the another CT scan finding that seem to be suggest the existence of mucormycosis. The reverse halo syndrome was seen in 15 by 16 patients within the week of the disease in new review of consecutive thoracic CT scan of leukemic patient with neutropenia. Other radiologic observations like numerous nodules appear late. The investigator suggests that the appearance of reverse halo sign on CT is the good indication of pulmonary mucormycosis in neutropenic leukemic patient with pulmonary infection. The reverse halo sign is the more prevalent in mucormycosis patient like 54% than the aspergillosis patient. While certain airway invasive characteristics, such as clusters of central lobular nodule, bronchial wall thickening, peribronchial consolidation, were more frequent in the aspergillosis patient. The positron emission tomography and computed tomography with 18F fluorodeoxyglucose is yet another emerging imaging strategy that may ultimately help in management and diagnosis of mucormycosis. Endobronchial ultrasound guided fine needle aspiration is needed in helpful screening techniques. Now, regarding culture and microscopic examination, clinical samples that are white allow for the quick preliminary analysis of the mucormycosis. Mucoral hyphae have the variable diameter and are non-septate and pauciseptate and have irregular and ribbon-like shape. The branching angle varies with wide angle bifurcation being common. Gomore's silver staining is often used to eliminate fungal hyphae, allowing for more detailed analysis of the anatomy. The presence of prominent infarct and angioinvasion characteristic, the invasive disease. Perineural invasion can be present when the nerve structures are involved. As compared to the non-neutropenic patient, neutropenic patients have more severe angioinvasion. Tissue identification, on the other hand, is an important diagnostic tool because it distinguishes between the existence of fungi as pathogen in tissue and presence of culture contaminant. Mucorale grow quickly in the most fungal culture media like potato dextrose and the sabrot agar inoculated at 25 to 30 degrees. Surprisingly, even though fungal hyphae are visible in histopathological examination, only 50% of the blood cultures are positive. Antifungal testing and species identification. Mucorale fungal are easily distinguished from Aspergillus fungal when grown in culture, when assessed by individual with expertise in fungal detection. ID3, ID32 kit and the API50CH have been successfully used for recognition of the Rhizopus pusillus, then Lichetemini acrombifera, as well as mucor species. Malditov mass spectrometry, that is matrix assisted laser deabsorption and ionization time of light, is the promising instrument, but it has not yet been validated for all mucors. Regarding serology, a reasonable test such as enzyme linked immunosorbent assay and immunodiffusion are evaluated based on the degree of their effectiveness. In three hematological patients who develop invasive mucormycosis, enzyme-linked immunospot assay have been used to identify mucorale-specific T cells. Then regarding molecular assay, conventional PCR, RF-LP and DNA sequencing of identified gene region uh, are all examples of molecular-based assay. The internal transcript spacer or 18S rRNA gene are the focus of majority of molecular assay. Studies performed for sensitivity and specificity shows the varied result, but a lower number of the patient examined being the critical shortcome. Molecular diagnosis from the blood and serum has yielded positive clinical result in 39% of cases. Now the advancement in the diagnosis. Histopathology and the culture were used to diagnose mucormycosis, and mucorale are the prone to vascular invasion and tissue damage in the organ they infect. Mucorales have long and non-septate ribbon-like hyphae with the branches at right angle in tissue specimen. Mucormycotic infection may cause neutrophilic, granulomatous, non-specific inflammatory changes, as well as angioinvasion and infarct in some cases. Fine needle aspiration biopsy may be used to confirm diagnosis when focal pulmonary nodule and the mass are present. Even if the histopathology reveals characteristic organism, cultures can be negative. Grinding tissue specimen for the culture also result in hyphae damage, due to scarcity of the septations which prevent the growth in culture. In mucormycosis, serological tests for D-glucan and Aspergillus galactomannan are negative. Rhizopus mucor, rhizomucor, and the leishtemia, contrary to PCR in serum and tissue, is available and may be superior to the culture. So this matrix assisted laser deabsorption ionization time of flight tend to be another tool with high precision for separating the mole from the culture. Next generation sequencing can detect the IMI in blood sample, which could lead to early detection of this infection. Now, regarding the clinical features of mucormycosis. Mucormycosis is divided into 6 types based on the anatomical location. The investigating locations were lungs, sinuses, soft tissues, skin, and dissemination. The profound cases were the rhino-orbital cerebral mucormycosis, happens in 27% of cases, lungs 30%, dissemination 15%, soft tissue infection 26%. Then regarding rhino-orbital cerebral mucormycosis is the fungal infection that can spread from sinuses to the oral mucosa, palate, brain, bone, and orbit. Rhino-orbital cerebral mucormycosis is the name given to this clinical condition. Patients with the poorly treated with diabetes mellitus are more likely to develop rhino-orbital cerebral mucormycosis. But it may also happen in single organ transplant and other immunocompromised hosts. In patients with poorly regulated diabetes, dental procedure can be the risk factors for rhino-orbital cerebral mucormycosis. Dental infections can lead to destructive infection of the mandible and maxilla. Headache, fever, nasal inflammation, facial pain, palatine mucosa, eschar, dark nasal, and periorbital swelling are some of the signs and symptoms of the problem. Cellulitis, chemosis, proptosis, blurred vision are all signs of orbital invasion. Intracranial progression through direct extension and angioinvasion can happen quickly. For good outcome from rhino orbital cerebral mucormycosis, aggressive and the rapid care is needed, including resection and surgical debridement as well as medical therapy. Then liposomal amphotericin B at high dose should be given at same time. Now regarding pulmonary involvement of lungs, perilegional ground glass opacities, centrilobular nodule, reverse halo sign, air crescent sign, lobar consolidation in the peribronchial upper lobe predominance, pleural effusion and bronchopleural fistula are the affected locations through invasion of the active envelope. Necrotizing pneumonia may occur when pulmonary vessels are involved. Aspergillus causes the offensive ulcerative tracheobronchitis at lung transplant and anastomotic site recipient. Rhizopus tracheobronchitis has also been observed. Pleural effusion and CT finding of the 10 nodules were importantly connected with the pulmonary manifestation. Now, regarding cutaneous involvement of the cutaneous mucormycosis can manifest as localized and disseminated disease in immunocompromised individuals. Traumatic injury, surgery, fires, natural hazard, war, insect and animal bite are also inoculation of the infected soil, trees, grasses, thorns, and water causes the cutaneous mucormycosis in the immunocompetent host. Mucormycosis is the fungal infection that spread quickly across the subcutaneous tissue, skin, bone, and fascia. So, this post-traumatic mucormycosis patient range from the non-traumatic mucormycosis patient in many ways, such as cutaneous localization, rarity of the underlying disease, short time before diagnosis, better 90-day survival rate, and the species in tropical and subtropical region, Apophyomyces and the Saxenia have become the most common species, causing localized cutaneous mucormycosis. Now, regarding gastrointestinal tract involvement, the introduction of the gastrointestinal tract by 12% to 11% in patients with the mucormycosis develop gastrointestinal involvement, which is fatal. Now, regarding therapy, mucormycosis is uncommon phenomenon causing deadliest opportunity in affected patients. Several research groups from the global organization are working on this problem. However, this liposomal amphotericin B can be employed as the first-line treatment to cure mucormycosis disease. OSA having mucorale activity was used as salvage and the induction therapy. Subsequently, surgical debridement served as the essential supporting role, especially when there is a participation of the soft tissue and the rhinocerebellum. The importance of reversing underlying risk factors such as glucocorticoid, steroid discontinuation, taper, neutropenia resolution, deferoxamine discontinuation, and the diabetes regulation and immunosuppression reduction cannot be overstated. Many antifungal are immune to mucorine. The most active agent include liposomal amphotericin B and the other new triazoles, posaconazole and the isoconazole. On the other hand, the echinocandins and voriconazole had deficient activity against the mucorale. Mucormycosis has been treated with liposomal amphotericin B for a long time. Isoconazole and the posaconazole have primarily been salvage therapy in patients who have developed resistance or intolerance to liposomal amphotericin B. Since mucormycosis can spread quickly, liposomal amphotericin B should be started as soon as the disease is suspected. A 6-day delay in amphotericin B-based therapy was linked to twofold increase in risk of death at 12 weeks after diagnosis between 1989 and 2006. So many studies indicate that liposomal amphotericin B outperforms the amphotericin B deoxycholate in terms of efficacy and protection. For mucormycosis, high-dose liposomal amphotericin B, that is 5 to 10 mg per kg per day, for minimum of 6 to 8 weeks, is assumed as first-line therapy. In one study of the single organ transplant patient treated with liposomal amphotericin B had the mortality rate of 15.4% compared to 59.6% for patient treated with amphotericin B deoxycholate. The most common involvement were lung, sinuses, and skin. Both the isoconazole and the posaconazole have the action against several molds and fungi, including mucorale. Although this amount of activity for both agent varies depending on the organism and mucorale genus. In refractory cases of mucormycosis, both posaconazole and the isoconazole have shown useful as an adjunctive therapy and salvage. Following initial treatment with liposomal amphotericin B, sequential therapy with posaconazole to complete therapy was effective. For patients with mucormycosis who has failed with liposomal amphotericin B or POSA, isoconazole has shown successful recovery therapy. For the European Medicine Agency has approved isoconazole for the treatment of mucormycosis where amphotericin B is ineffective. So isoconazole can be given as a loading dose of 372 mg of isoconazole sulfate every 8 hours for 6 doses and maintenance dose that is 372 mg of isoconazole sulfate. In India, the current guidelines indicate 0.5 to 1 mg per kg per day intravenous methylprednisolone for 3 days in moderate instances and 1 to 2 mg per kg per day in severe instances are very helpful. Dexamethasone, that is 6 mg per day for maximum of 10 days, is recommended by the National Institute of Health in patients who are ventilated or require supplementary oxygen but not in milder instances. Now regarding the combination antifungal therapy. Combination therapy was not shown to be superior to the monotherapy in retrospective review of the patient with mucormycosis complicating hematological malignancies. The effectiveness of the combined antifungal therapy for mucormycosis is unknown due to lack of evidence. Hence, there is need of experimental setup for observing the alteration in the given therapy. Now, regarding surgical therapy, dissection and the surgical debridement play a vital role as an adjunctive treatment in the mucormycosis. Now, this is the schematic representation of the treatment of the mucormycosis. Mucormycosis treatment, first we have to reverse the underlying cause. That is, we need to control the hyperglycerol, taper the steroid, and we have to hold immunosuppression. So, the primary therapy is isoconazole, posaconazole, and amphotericin for 3 weeks. Then we can also offer the combination therapy. Adjuvant therapy is the ion chelator, hyperbaric oxygen, interferon, granulocyte macrophage, colony stimulating factor, and soda back. Surgical construction include debridement and the extensive targeted lesion. Then salvage therapy includes isoconazole, posaconazole, and rizin amphotericin B for 10 mg per kg dose. Then regarding ion chelator, this uh, Deferral is the kind of iron chelating agent that increases longevity in the mice with diabetic ketoacidosis. Deferral was seen to be very effective in patients against a liposomal amphotericin B treatment. Salvage therapy is provided when the patient does not respond to the normal first line treatment with amphotericin B. The assessment of the antifungal medication failure necessitates the caution. Switching to the different class of antifungal agent is the principle of the salvage therapy. However, the mucorales are the only susceptible to the two type of antifungal agent. In this case, options are to increase liposomal amphotericin dose or switch to the posaconazole or isoconazole. Now, the role of antifungal prophylaxis. It is still under investigation whether antimucorale antifungal should be used for primary or secondary prophylaxis in the high-risk individual. Osaconazole is the strongly suggested as the main prophylactic to prevent invasive fungal infection in patients suffering from the severe neutropenia. Monitoring serum posaconazole level during chemoprophylaxis is also displayed to document appropriate antifungal absorption and therapy compliance as undetectable serum level increase the risk of breakthrough infection. Isoconazole could be the another option based on the result of recent clinical trial. Now we'll see the table 3 and table 6 which was described in this article and are relatively important. So table 3 describes the antifungal drug we use to treat mucormycosis and the summary of the recommendation is posaconazole. Posaconazole can be given as IV or tablet that is 300 mg from the day uh, from day 2 then this 2 into 300 mg day one. Oral suspension, if we are giving in the oral form, then the 2 into 400 mg per day or the 4 into 200 mg per day. If amphotericin B, if there is a CNS participation, 1 mg per 100 gram per day of liposomal amphotericin B. If there is no CNS involvement, then 0.5 mg per 100 mg per day of liposomal amphotericin B. So for posaconazole, the total duration of therapy is 6 months. For amphotericin, the total duration of therapy is 6 to 12 weeks. Then we can give the combination therapy like isoconazole and posaconazole and liposomal amphotericin B. Liposomal amphotericin B plus echinocandin. Then we can also give the isoconazole in the form of IV and oral, that is 3 into 200 mg on day 1 and 1 into 200 mg per day from day 3. Total duration of therapy is 3 months. So now we'll see the table number 6. In this, they have mentioned the group of the patient intervention treatment. So, patient who are fever driven or empirical, that is a patient group that is unresponsive to antibiotic, febrile neutropenia, image shows reverse hallucination, electromagnetic negative, and the other typical presentation and the multiple nodule. Then we have to intervene with the liposomal amphotericin B. Then for prophylaxis, graft versus host disease and prolonged neutropenia, single organ transplant, adult, prolonged neutropenia, heart and lung, immunocompromised due to previous mucormycosis diagnosis. Then for intervention we can use posaconazole, that is IV and IV in the IV form or the tablet form. That is 600 mg on day 1 and the 300 mg from day 2. So isoconazole intravenous or oral form can be used. That is 600 mg on day 1 and 2 and 200 mg per day from day 3 and 200 mg per day from day 1. In same patient, surgical resection and the last medicine effective as secondary prophylaxis. Switch from amphotericin B to the posaconazole after 3 to 6 weeks if practicable. Then regarding salvage therapy is practiced in the refractory disease and the toxicity to the primary therapy. So in salvage therapy, we can intervene with the isoconazole intravenous and per oral form. That is 600 mg days 1 and 2 and 200 mg from day 3. Posaconazole tablet and the intravenous. Posaconazole can be given as a tablet and the intravenous form. That is 300 mg on day 1 and the that is 600 mg on day 1 and 300 mg from day 2. Amphotericin B and the lipid formulation can be used in the dose of 5 to 10 mg per kg. Lower doses in the renal toxicity. So that's all about the mucormycosis. We'll meet in next lecture.